Welcome to All Things Cardio-Oncology. My name is Steve Caselli. I'm the Executive Director of ICOS. And in this podcast, you'll hear from a diverse representation from our community. We want you to be both informed and inspired by their stories and experiences, and we're so glad that you've joined us today. Well, it's good to be here again today with my co-hosts Dan Lenahan and Arjun Ghosh. Welcome to both of you. How are you guys doing?
Fantastic. Thanks, Steve, as always. Look forward to hearing what Arjun has to say about all the various interesting topics in cardio-oncology.
Welcome, Arjun.
Thanks very much. Looking forward to be here today and to hear from Markus about the interesting trial that he was involved with.
Yeah, one of the things that makes our work so interesting and rewarding is that we actually get to interact with people from all over the world in the cardio-oncology community. And we are excited to welcome today one of our colleagues from Germany, Dr. Markus Anker. Markus and his team published results in the European Heart Journal of a recent trial that they conducted. The title of the publication was Heart Failure Therapy in Patients with Advanced Cancer Receiving Specialized Palliative Care. So a very focused study that we're excited to talk with you about, Markus. Welcome. We're glad you could join us today. And I wonder, we'd like to ask our first-time guest to just share with us a little bit about your personal background educationally, and in particular, how you developed your interest in cardio-oncology.
Thank you very much for having me today. I'm Markus Anker, and I'm joining you today here from Berlin, from the Charité in Germany. So about my background, I started back then with my dissertation and my medical doctorate thesis about heart rate in cancer. What we saw there was that if the heart rate is elevated in cancer patients, this is a significant prognosis marker for mortality and associated with all kinds of reduced morbidity in these patients. And this then turned into an observational study that I continued. This then turned into a registry called Anker registry. And then I'm also a cardiologist in Berlin, Germany. And then a couple of years ago, we started the EMPATHIC trial, which we're talking today about.
Great. Thank you for giving us a little bit of context. And maybe you could just begin by, again, telling us a little bit about the study itself and how you developed your interest in this particular space.
Sure. So first of all, to catch everyone up on the trial and what we do in the trial. So first of all, we included patients with solid cancer, UICC stage 4. So the most advanced stage there is in solid cancer patients. All the patients were in a palliative care setting and with a life expectancy of 1 to 6 months at baseline, and criteria for cardiovascular problems and symptomatic limitation. And the aim was to include at least 72 patients, and in the end we did include more patients. Even 93 patients were randomized. And they were randomized in a double-blind fashion to either receive a heart failure therapy that was constructed out of sacubitril valsartan, empagliflozin, ivermectin, and intravenous iron, and that was then randomized versus placebo. But both groups were allowed to use diuretics as their treating oncologist thought was best for them, and the trial duration for the double-blind phase was just 30 days. And then followed another 30 days of open-label therapy where all patients could get the heart failure therapy if they wanted. The primary, very novel endpoint of this study was days life and being able to wash oneself, 4-meter walking ability, and patient global assessment, together analyzed as a win ratio, and then some secondary endpoints, for example, again, quality of life, NT-proBNP, and ejection fraction. And the trial ran in 5 sites in Germany, also under the guidance of Tino Schrassow. Berlin, Essen, Heidelberg, Leipzig, and Homburg-Saar. And this is only one of very, very few trials in the world ever doing a double-blind, randomized fashion on a palliative ward, pretty much, in such cancer patients with very limited life expectancy. And you also asked how did this all start actually? How did this whole idea come around? So it all started pretty much with a paper that we a couple of years wrote about, where we looked at the washing ability and the 4-meter walking ability of cancer patients treated in a specialized palliative care setting. And we saw that not being able to wash oneself and not being able to walk 4 meters were significant predictors of mortality in these patients. And we also talked to patients and patient representatives, and they told us that the washing ability and the walking ability in this setting are very important for these patients and for their self-care ability. Since we also have seen that cancer patients in very advanced stages often show cardiac wasting associated cardiomyopathy, we started thinking about which heart failure medications we could test and how they could possibly influence the self-care ability of these patients. And so we came up with a multi-heart failure drug trial design, where we used sacubitril/valsartan, empagliflozin, ivabradine, and intravenous iron, but always only in those patients that we seemed fit for these medications, meaning sacubitril/valsartan and empagliflozin only if blood pressure was high enough, meaning above 95 or above 100 millimeters mercury. Ivabradine, we only gave those patients with sinus rhythm and a heart rate above 75 beats per minute, and intravenous iron only to those patients with a documented iron deficiency, meaning TZAT below 20%.
Yeah, I think, Marcus, thanks for the explanation. I think that, it's interesting, when you look at the heart failure space, and especially advanced heart failure. And, there were a couple of trials actually not that long ago, I would say about 5 or 6 years ago, where they were looking at palliative care in an advanced heart failure setting and they randomized patients to a sort of palliative care approach and education, and focused on specifically palliative treatments versus not doing those things, and what were the outcomes. And I don't recall exactly if there was a specific hard endpoint that was better in the palliative care group aside from sort of quality of life. So quality of life in the way that they measured it was clearly a lot better when you focused on palliative care type control of symptoms. So, that's widely recommended in advanced heart failure. So equating that sort of general principle to the advanced cancer story, I mean, it's kind of interesting that you came up with this. And what sort of quality of life measure, I think you sort of said it, I guess, ability to walk a short distance, or the ability to wash themselves, or self-care was the main point, that you were trying to address. Do you think that was the right quality of care measure? Do you think that was the thing that was most important to the patients?
Yeah, that's a good question. So first of all, what we did learn and what we did see is that the washing ability and the walking ability of just 4 meters were very dichotomous variables, meaning once patients were not able to wash themselves anymore or not able to walk 4 meters anymore, it was very hard to influence these endpoints. And therefore, the combining of these primary endpoints of the study was not significantly changed in the end, because it was just very hard when the patient is at a point where they can't do that anymore. And washing ability meaning you can't use a swab, like a swamp or swab when you're lying down in bed anymore, meaning it's a very far advanced stage. We learned it's very hard to influence this, at least with a heart failure therapy. We are thinking about how else you can influence this maybe. And maybe there's other drugs that can influence these specific endpoints, maybe anabolics, could be tested if you would want to influence exactly these endpoints. But we also looked at patient global assessment, and here pretty much asked the patient, did you feel better than at the last visit? And here we did see positive influences on this question. So PGA was significantly influenced. That was one of the secondary endpoints. So we are seeing it's very important also with these quality of life questions. Which question exactly are you asking? And what are you trying to make better for the patients? Exactly.
Thanks so much, Markus, for that interesting introduction. And I think one of the main things that struck me when we saw the paper and we were talking about discussing it with you was, of course, the palliative care setting. And of course, a lot of our oncology patients ultimately do end up on that pathway. And sometimes there's a reluctance from the cardio-oncology team, from the cardiologist, to engage necessarily in the high level cardiology care of those patients at that point. Sometimes it's left to the palliative care teams. So maybe kind of looking at it from the first principle side, why were you interested in this setting in the first place, and what suggestions can you give to engage more cardiologists and more cardio-oncologists to be actively, appropriately engaged in managing the palliative patients?
So it's a good question. So first of all, what's very encouraging in this trial is what we did see is that patients were very welcoming and they were very open to this trial, and they were very willing to participate in this trial. Only very few patients dropped out of the trial unrelated to disease progression. So only 3 of 93 patients went out of the trial early and due to unrelated and not related to disease progression, meaning patients were willing to participate in this trial, and they also very well tolerated the therapy. And this is also very interesting when you look at the adverse events and the significant ones. You see that hypotension was not more than in the placebo arm, actually. That was also very encouraging. Many people would think that giving sacubitril/valsartan could be a problem, but we saw this is very safe to do. Of course, patients were well followed up, especially in the beginning of the trial. We looked closely at the patients. They were very often treated on a ward at the beginning of the trial, so it was easy to follow up the patients. But we did see that the patients very well tolerated the therapy. And also interestingly, so the first analysis was done after 30 days. That was the primary outcome, which was not significantly affected. But the secondary endpoints, they were affected, meaning that left ventricular ejection fraction increased by 2.9% within just 30 days. NT-proBNP, and this is quite amazing, decreased by 41%. Within 30 days, and the self-reported subjective patient global assessment score, which is a very sensitive measure of patients feeling better with the treatment, was significantly improved. So this is very interesting for future trials, and we have learned a lot in this trial. And we're very much looking forward to doing another trial in this field, and we think we've learned a lot on how to design a possible follow-up trial.
Yeah, I mean, I think that's really, really amazing work, because as mentioned, it's often our reluctance, historical maybe, to actively engage. And I think what you're trying to show is that they can get a meaningful, tangible, clinical, symptomatic, as well as echocardiographic or biomarker benefit as well. So I guess my question would be, when we're trying to maybe do the bench to bedside and translate this into clinical practice, is it very much about choosing the appropriate palliative patients that we should be focusing our energies on? And what is the best way to get the maximum benefit for these patients without unduly causing any side effects, and which is the thing that we're always worried about in this situation, I think.
So what we learned there's something very simple in this trial, which is that the patient with cancer need to be alive for a minimum amount of time, say, for example, in this case, at least 4 weeks, to derive benefits from a heart failure therapy. This seems obvious, but in the design of a clinical trial, it is difficult to just exclude the first 30 days of follow-up. And overall, we also learned that even for a setting in very advanced cancer as here, the trial duration should be somewhat longer, maybe 3 to 4 months actually. And maybe at the beginning, we targeted here patients with 1 to 6 months expected survival time at baseline, but maybe it should be more like 3 to 12 months to give the heart failure therapy a chance to actually make the patient derive benefit from it. And we think that symptom relief and better quality of life or self-care ability are very important endpoints in these patients. We have to further test how heart failure drugs can help us improve such measures in the patients. But of course, there may also be other drugs that could help. As we said before, maybe anabolics could, for example, help just with muscle strength, for example, and giving patients the needed muscle strength again to maybe walk again 4 meters, as was the goal here, the primary goal.
Sure. I mean, interested to hear your thoughts, Dan, because it really is a paradigm shift maybe in the management of these patients, because I think Markus very nicely mentioned that hypotension was not a factor compared to placebo, which is often the first reason that allegedly, these drugs are stopped in the palliative setting. So I don't know in the States and elsewhere, how we would kind of implement such an approach.
Yeah, I think this is a very difficult question. For example, Marcus, I agree with your comments that you probably need at least 30 days, probably more like 60 or 90 days to derive a substantial documentable benefit from heart failure therapy. So, that's just sort of a practical point of view. I think if you look shorter than that, even just, giving iron infusion, it's not expected to really make a big difference in your hemoglobin for 30 to 90 days, depending on, how bad their anemia may have been or iron deficiency may have been. So I think that, it takes time for those drugs to exert a positive effect. So there's that. And then the other part is, again, I guess I suppose I go back to the quality of life. I mean, if that is the main measure, that is the thing that you're hoping to improve. How do you measure that in this population? And if you think about some sort of quality of life tool that's been validated in different contexts, none of them are going to fit in this space. So if you talk about like in the States, they might use the Kansas City quality of life score for heart failure. It's like 25 questions. It's validated in the heart failure population. It's not validated in a cancer population. And then when I was at MD Anderson, we had Medasi, MD Anderson Symptomatic Index, I think is what it stands for. And that was certainly validated in a cancer population, but it's sort of the same story that it looks at all these different domains and it asks 25 questions. And I mean, that in and of itself is extremely fatiguing for a patient who's so sick. So in the end, when you're talking about some quality of life measure, either you made one yourself, which maybe it's this 12 meter or 4 meter walk and the self-care ability. If that's what your measure is, then, I think that's a great idea. The EQ5D is only a total of 6 questions, and most people can answer that. So I would be curious, based on your trial, what tool do you think is the most reactive to improved symptom control. And, would that be the tool that you would use in any subsequent study? So I don't know. It's really hard to measure quality of life reliably. And when you have two major disease states, so the cancer, whatever the cancer is, plus heart failure on top of that, you know, there there are no tools that are validated in both of those disease states.
Absolutely, that's an interesting question. And here you need to find, as you're saying, a balance between what a patient can do and the amount of data you need for analyzing your endpoints. For example, we asked the patients in this trial every 10 days how their washing ability was in the last 10 days. But of course, it would be much better to ask the patient every single day live how their washing ability was today or how their walking ability was today. But you have to think about whether your patient is going to want to do that, whether they want to have a phone call with you every day. If they are so sick currently, they probably don't want to talk to a physician every single day. That's
Probably
that's
not.
why we are exactly. And because then you're going to lose patients because they're saying this is too much effort for me. This trial, I'm dropping out of the trial, which you also don't want. So potentially you could also think about an app that could help with this, that asks you every single morning how you're doing or about your quality of life. Or you can think about wearable devices of some kind that, for example, count the number of steps you're doing. That could even be a watch, which might be possible for most patients to wear. But of course, you have to think about, this is probably a elderly population you're looking at again, whether they really want to have some kind of smart tool, whether they really want to learn this just now, how to use that tool. And
yeah, I think that these are challenging questions, but I would say, uh, you know, I can't really imagine any patient would want, a contact every day.
exactly.
They might be willing to do it once a week or certainly once a month, but for sure not every day. I mean, they're not feeling well, and you don't they don't want to have. And I mean, if you just think about your own personal reactions to the surveys that you get every time you take your car for service, or you go to the checkout counter at a grocery store and they send you some survey, I mean, you're not really excited about filling it out.
Exactly. And you asked about questionnaires. There's the EORTC QLQC 15. That's 15 questions. There's another one, a heart quality of life. I think that's about 14 questions. Also not that easy to do. But in this trial, we used the patient global assessment, and we learned this is kind of an easy question, which just gives you a fair, quick answer. It's like a 7-point Likert scale. And you ask the patients, do you feel better? Do you feel a little bit better or much better or a little bit worse or much worse on a 7-point scale? And you pretty much ask them always from visit to visit how they're feeling in comparison to the last visit again. That gives you a fair good opinion on how the patient is reacting to the therapy.
Fantastic. So, Arjun, I mean, what do you think about this? I mean, does this study influence how you're going to address these situations going forward? What do you think?
Yeah, so I think this study has kind of massive implications in terms of how we look at these patients, because as I mentioned, I'm speaking, of course, on the UK perspective, and very much after a certain viewpoint. If they are under the palliative care team, it's the palliative care doctors and nurses who manage the patient, and the attitude is very much for symptom relief. And as mentioned, anytime the patient says, "I'm a little tired, fatigued, dizzy," which is obviously very, very likely in this situation, the first thing that happens is that their cardiac medications are decreased or stopped. And I think that the interesting thing here was that the hypertension was the same as placebo, which is a powerful message, I think, to say, actually, you can consider carrying on with these medications if they are going to make the patient feel better. So I really think that this is a powerful first piece of work to actually say to the palliative care community and to the oncologists that actually we would be interested to help manage these patients. But it's fine, I think, for me to say that, because even from the other side, from the palliative care side, there may well be some degree of, not necessarily resistance, but some degree of surprise that the cardiologists are now interested in this, whereas from their perspective, maybe these drugs are not necessarily the best drugs, and more important is, of course, pain relief and keeping the patient comfortable. So I think it would require a two-way dialogue. Luckily, in cardio-oncology, we're very used to talking to other specialties and having those kind of, two-way, three-way dialogues. But I think it would require a tremendous amount of work. So I think, again, just want to thank Markus for taking the time to talk to our audience about this topic, because this really is a very novel and different, radically different approach, I would suggest, to what we're doing now, at least in the UK, for these patients.
Markus, thanks so much for your time. Do you have any closing summary thoughts for the community in terms of how to go forward in this space?
I think it's a very interesting space, as we all know, the cardio-oncology space, and I'm hoping that we're doing more trials, and we also want to motivate people here. It is possible in pretty much any scenario to do double-blind randomized trials in cancer patients also, and we think that's very important to do here.
Yeah, we certainly commend you for that. Every podcast we host, everybody says we need more data, we need more trials, and so we commend you for your efforts in that direction. And we really look forward to your follow-up study. You said you had some ideas, so we'll look forward to that, and we'll have you back on the next time you have some data for us. So thank you so much for being with us today.
Thank you for having me.
Thank you, Markus, and Arjun, and Steve. Always great to hear your guys' thoughts on how things are going in cardio-oncology.
For more information about ICOS, you can go to ic-os.org, where you'll find more information about all of our programs, including our weekly webinars, our board certification exam, and other resources that we know you'll find helpful. Thanks for joining us today, and we hope to hear from you soon.
Free audio post-production by alphonic.com.